Hello. In this video, I will explain the most frequent anomalous innervation of the intrinsic hand muscles. The name given to this entity is Martin-Gruber Anomaly. But first, I strongly recommend you take a look at our previous YouTube video on the classical innervation of the intrinsic hand muscles. I will briefly review the normal innervation of the intrinsic hand muscles. Every motor fiber destined to innervate the intrinsic hand muscles upon reaching the distalmost region of the medial cord must make a decision to either join the median nerve or the ulnar nerve. Most of the time, by way of the mediolateral branch of the medial cord, the motor nerve fibers of the loaf muscles of the thumb join the median nerve. These motor fibers are those for the first and second lumbricals, opponens pollicis, abductor pollicis brevis, and the superficial head of the flexor pollicis brevis. In this drawing, you can see why the acronym LOAF is used to label these fibers. Notice that the first letter of each of these muscles is in white. The rest of the nerve fibers for the intrinsic hand muscles, by way of the medial branch of the medial cord, join the ulnar nerve. These fibers include the third and fourth lumbricals, opponens digiti minimi, abductor digiti minimi, and flexor digiti minimi. These are also known as the hypothenar loaf muscles. In addition to the hypothenar muscle fibers, the adductor pollicis and the dorsal and palmar interossei fibers also travel with the ulnar nerve. Once these fibers have joined the median and the ulnar nerves, they travel through the arm and the forearm. And upon reaching the hand, these fibers separate to innervate the appropriate muscles. Now, let's start our description of the Martin-Gruber anomaly. This anomaly is the result of a routing mistake and a subsequent rerouting correction. I will first describe the routing mistake. The routing mistake takes place in the distal segment of the medial cord of the brachial plexus. Normally, fibers that ultimately innervate the median hand muscles travel with the median nerve, indicated by the aqua arrow. Likewise, fibers that ultimately innervate the ulnar hand muscles travel with the ulnar nerve, indicated by the magenta arrow. This is not the case in individuals with Martin-Gruber anomaly. In individuals with Martin-Gruber anomaly, fibers destined to innervate ulnar hand muscles mistakenly join the median nerve at the distal segment of the medial cord. The classification system used for Martin-Gruber anomaly is based on which fibers destined to innervate ulnar hand muscles enter the median nerve. So, Martin-Gruber anomaly is divided into three types and multiple subtypes. The first type, Martin-Gruber anomaly type 1, affects the fibers of the abductor digiti minimi. The type 1 Martin-Gruber anomaly has two subtypes. In the most common of these two subtypes, Martin-Gruber type 1a anomaly, fibers destined to innervate the abductor digiti minimi, instead of going to the ulnar nerve, represented in magenta, go to the median nerve, represented in aqua. Please notice the trajectory of the abductor digiti minimi in this depiction, represented by the brown line. In Martin-Gruber anomaly type 1b, only some of the fibers destined to innervate the abductor digiti minimi go to the median nerve, while the rest go to the ulnar nerve. In this drawing, the fibers for the abductor digiti minimi are presented as dashed brown lines. The misplaced abductor digiti minimi fibers in type 1a and 1b continue distally through the arm. Here, the aqua line represents the median nerve, the magenta line represents the ulnar nerve, and the brown line represents the misplaced ulnar fibers now traveling in the median nerve. The abductor digiti minimi fibers, up to now traveling with the median nerve, may either continue in the main trunk for a short distance and then depart from it, going across the middle region of the forearm to the ulnar nerve. Or, the misplaced digiti minimi fibers separate from the main trunk of the median nerve at the level of the proximal forearm, and join the anterior interosseous nerve, indicated by the green arrow, traveling in this nerve for a short distance, and then depart from it, and transverse the middle forearm region to reach the ulnar nerve. In Martin-Gruber type 1A and type 1B, all abductor Meneemi fibers previously traveling in the median nerve cross the forearm. This crossing represents the rerouting correction that we previously mentioned. All the abductor Meneemi fibers, now traveling in the ulnar nerve, then transverse the wrist via the Guyon canal. Once the digiti Meneemi fibers cross the Guyon canal, they innervate the abductor digiti Meneemi. Recall that, earlier in this presentation, I mentioned that Martin-Gruber anomaly is the result of a routing mistake occurring at the brachial plexus, and a rerouting correction. The rerouting correction occurs when the abductor digiti Meneemi motor fibers cross the forearm from the main trunk of the median or from the anterior interosseous nerve to the ulnar nerve. In the previous few slides, I explained the relevant details of Martin-Gruber anomalies type 1A and B. I will now summarize our discussion of types 1A and B and contrast them in relation to Martin-Gruber types 2 and 3. Martin-Gruber type 1 involves the abductor digiti Meneemi fibers. The fibers for the abductor digiti Meneemi, usually at the distal most region of the medial cord, take the medial branch, thus reaching the ulnar nerve. But in patients with Martin-Gruber anomaly type 1A, all of the abductor digiti Meneemi fibers take the median nerve route. While in Martin-Gruber anomaly type 1B, only some of the abductor digiti Meneemi fibers take the median nerve route. These are represented by the dashed lines. Please take a moment to notice the trajectory of the abductor digiti Meneemi fibers in the brachial plexus and in the forearm in Martin-Gruber anomaly type 1A, where all the fibers travel with the median nerve. Here they are represented by the brown line. And in type 1B, where only some fibers travel in the median nerve, then join the ulnar nerve at the forearm. Martin-Gruber type 2 is the most common of the three types of Martin-Gruber anomaly and involves the first interosseous muscle. The fibers for the first interosseous muscle, usually at the distal most region of the medial cord, take the medial branch, thus reaching the ulnar nerve. But in patients with Martin-Gruber anomaly type 2A, all of the first dorsal interosseous fibers take the median nerve route. While in Martin-Gruber anomaly type 2B, only some of the first dorsal interosseous fibers take the median nerve route. These are represented by the dashed lines. As you can see, the routing mistake in type 2A occurs at the distal portion of the medial cord and consists of all fibers destined to innervate the first dorsal interosseous muscles, taking the median nerve route. The rerouting correction takes place in the forearm. Whereas in Martin-Gruber type 2B, the routing mistake occurs in the distal region of the median cord, but only involves some of the first dorsal interosseous fibers. The rerouting correction in type 2B also occurs at the level of the forearm. Lastly, Martin-Gruber type 3 involves the deep head of the flexor pollicis brevis and the adductor pollicis. The motor fibers intended to innervate the deep head of the flexor pollicis brevis and the adductor pollicis normally pass through the medial branch of the median cord to reach the ulnar nerve. In Martin-Gruber anomaly type 3, these fibers instead take the median nerve route. As you can see, the routing mistake in type 3A occurs at the distal portion of the medial cord and consists of all fibers destined to innervate the flexor pollicis brevis and the adductor pollicis, taking the median nerve route. The rerouting correction takes place in the forearm. Whereas in Martin-Gruber type 3B, the routing mistake occurs in the distal region of the medial cord, but only involves some of the flexor pollicis brevis and adductor pollicis fibers. The rerouting correction in type 3b also occurs at the level of the forearm. So, when you think of Martin-Gruber anomaly, remember the only gross anatomical finding is at the level of the forearm. This is the rerouting correction of a routing mistake that originally occurs at the level of the brachial plexus. Thanks very much for watching.